This talk actually came about as a result of last year's panel. And so we were sitting on the panel and we were talking about multidisciplinary collaboration. And I think everybody said, oh, we've got this many meetings. You know, we do our heart team rounds, we do heart team this. Everybody kind of said at some point we got to start doing work, right? Nobody can actually sit in a multidisciplinary meeting 5 days a week because somebody's got to pay the bills. And I actually raised my hand and I said, well, actually in our system, we're not RVU driven. We're a capitated healthcare system. So we can basically have as many heart team rounds as we want. And I think that maybe was the impetus for inviting me to do this talk. So thank you. So I don't have any disclosures, but I do work in a capitated healthcare system, and I actually like it. So that may shock many people. And really the goal of this talk is to say that it is possible to embrace innovative technology in this healthcare system, in an integrated healthcare system. And more than possible, I would actually argue that it's an ideal setting to do so. So maybe the opposite of what you might have been thinking. And when I say embracing technology, I'm not talking about a conveyor belt to give healthcare to the masses, where it's one size fits all. That may be a myth about this type of system. And there are a few other myths that I'd like to dispel. Some people would think that the incentive is to provide less care instead of more, that physicians have less autonomy, and that we're good at prevention, but if you get sick, you're kind of screwed. And that it's very much a gatekeeper system. And actually, when I took my job, my attendings warned me. They said, don't do it, change your mind, find another job, because you're going to have to ask permission to do expensive procedures. And so I was really starting to worry after I took my job. And I started to have second thoughts, and that's me. So I started to worry, is there going to be red tape that I'm going to have to deal with? Am I going to be not allowed to do cutting-edge therapies that I trained to do during my fellowship? And really, this kind of came to a head when I had my first PFO patient scheduled to see me in the office. And to give you an example of why that's so disturbing, not because the procedure was so hard and I didn't think I could do it, but it was really because it was an era where the landscape was very different than it is right now. All the PFO trials and registries were closed. There was no contemporary long-term follow-up data to support PFO use routinely for patients with cryptogenic stroke. There were no FDA-approved devices. Everything we did was off-label. And I remember fondly the hours of paperwork that I did during my interventional training to try to get insurance companies to approve PFO closure. And I also remembered my attending saying, remember all this. If our insurance companies won't let you do it, your capitated healthcare system is never going to let you close a PFO. So you might as well just forget what you learned. And so when I had my patient on my schedule, I asked a senior colleague before I saw the patient. I said, what am I going to do? Like, I think he probably needs it. And my colleague basically said, if you think the PFO needs to be closed, just do it. What do you mean just do it? Do I have to ask? Is there like some pre-authorization form I'm supposed to fill out? And the answer was no. Just document in your note why you think it needs to be done and then schedule the patient and do it. And then he said, if there's anything else you want to do that too. And I was blown away. So I didn't really understand, but I was very invigorated and I was ready to get to work. So there are a few caveats. Not all capitated healthcare systems are created equal. And my experience at Kaiser really has informed my opinion. So that's really what I'm going to be sharing here. But hopefully there are a few key items that can be translated to all healthcare systems and will help to allow people to embrace new technology. And these are basically them. So I would say that the most important thing is that physicians need to make all medical decisions. And you may think that's counterintuitive in a capitated healthcare system, but actually we're protected from the financial decisions completely. Our organization is two separate entities. There's the financial side that's dealt with by the insurance companies. They own the infrastructure and the buildings. And then there are the doctors. And the doctors actually determine what services are provided and in what systems we provide them. Which hospitals provide cath lab access, which hospitals provide OR services. And if there's something that we decide we're not going to offer internally, then we just ship it out to another system and we pay, and then the other group pays the bill. So there's actually tremendous incentive for us to be able to do everything and anything because it's more expensive when we send it out. The other thing that's important is it's nice to concentrate expertise. And I would argue that in a capitated healthcare system, you can enforce this. You don't have to have 20 centers doing TAVR in one geographic area. You can actually dictate which hospitals are allowed to do these procedures. You can create concentrated experience, improve outcomes, and increase proficiency in the novel techniques. And then I think multidisciplinary collaboration is absolutely key. We need to tear down the silos, and I would argue this is the point where the capitated healthcare system actually is the strongest. So, in a physician-run healthcare system, the important things to remember, we want to prevent chronic disease. That's very important. That's how you keep costs down. That's how you keep people healthy. But you also have to be able to provide cutting-edge subspecialty care. And if you're a physician-run organization, you're going to make sure that you can do that. So in our capitated healthcare system, we embrace new technology. We basically want to provide cutting-edge technology, and our goal is to be a major competitor for all of the major university settings. You have to extensively report your quality so that you know if you're doing a good job. And you have to analyze things on a large scale. So we actually have a captive audience in our system. Anybody who leaves our healthcare system and gets care outside of Kaiser, it has to get paid for. So we know exactly what happened to every single patient. I would argue possibly even better than Olmsted County, because we have basically a small country where we know exactly what is happening for everybody. So there's a lot of population health data, and I can go to my administrator. If somebody says, oh, that mitral clip is too expensive, if you're doing that off-label, I can say, well, look back at all of the patients who got readmitted for heart failure, and I'm going to save you money because you're going to have 5 less hospital admissions. And so we can use this data against them, and actually it works out really nicely. And we have a large clinical trial network within our system. So KP National has a pretty small footprint. We're about 12 million members in various states. And I'm really just going to focus on the Northern California situation because that's really where I work. We're based in San Francisco, and we have a referral network that expands all over the Northern California region for people that come from miles and hours away. We have 4.1 million members, 22 hospitals, 14 cath labs. Amazingly, it's all the same physician group. So when we talk about diagnosing disease and informing our colleagues of what the new technologies are, I can do so with the hit of a button. I can just send an email out. We can have WebExes, educational conferences for the whole system where everybody knows what the new trials are that are coming through. And we have one medical record, so I can see every single person's echocardiogram, no matter where they're based. And I don't have to repeat it if it's of reasonable quality. So we do use the hub and spoke model. We do concentrate expertise, and I'm going to talk mostly about the structural heart experience, because that, I think, is the most relevant. So if you're a referring cardiologist and you're based 2.5 hours away from our center, and you see a patient who's got severe AS or severe MR, all you have to do is hit a button on your computer screen while you're typing your note that says refer for TAVR, refer for SAVR, or whatever it is. And it pops over to us instantaneously, and our group can sit there and go through exactly what it is, set up a consultation visit, and then move forward. I can see all of the data that's already on the other side. I can look at the echo images immediately. Nobody has to bring a CD, so I can look at the images. I don't have to repeat an echo, so I'm saving healthcare costs there. I can look at cath information. And then, as I mentioned, I can basically notify the entire network with a hit of a button. This is the new trial that we are offering. This is a new therapy that's available. So we penetrate very quickly. And it's unique because it's a no RVU system, so I don't have to worry about accounting for anybody's individual productivity. As long as you show up to work and you'll get your salary, and you do whatever you need to do to make sure that the patients are getting taken care of. So we have multiple meetings per week, probably more than any, I would argue, more multidisciplinary meetings in cardiology than any other medical center. We have an imager, we have an interventional cardiologist, a CT surgeon, and a heart failure specialist, all in the same room every single time we discuss cases. And much like most other institutions, it started off with a multidisciplinary TAVR clinic or a TAVR board where you would review cases, upcoming TAVR procedures. But we've kind of gotten away from procedure-specific meetings, and we're actually moving more towards disease process meetings. And this, I think, is very, very exciting. So if you think about the typical AS pathway, somebody with severe aortic stenosis who's symptomatic basically falls into one of these 3 categories. And this is basically what we all use in the room to decide who's going to start to steer towards SAVR or start to steer towards TAVR with growing expansion and growing indications. So the typical model is patient gets referred to cardiac surgeon. Cardiac surgeon sees the patient. Cardiac surgeon says patient is high, medium, or low risk. And then at that point, start down the TAVR pathway if you think that they're a TAVR candidate. And then you probably have to set up another visit to meet the interventionalist. You might have to get a CT scan and kind of go down the road. And that kind of takes a while. So what we do now is we actually hold at least twice weekly reviews where we review all of the aortic stenosis consults, whether they be for SAVR or for TAVR. And it's me, the interventionalist, our surgeon, and our imager. And we sit there and we review all the data. We look at the echo and we decide, does this patient truly have severe AS? If the answer is no, we might recommend additional studies to clarify whether they do. If the answer is yes, then we start to think very quickly. Does this patient look like they're headed down the TAVR pathway, or do they look like they're headed down the SAVR pathway? And so by looking at some of the studies that have already been done through the health medical record that's already at our fingertips, before the patient even travels from their home, we already have a very good sense as to whether they're a good candidate or a bad candidate for one particular therapy or another. And then we can go back and forth. And the goal of this system is so that when we actually meet the patient, we already have a plan. We have plan A, plan B, plan C, and then we can basically confirm that plan or move to the next plan on the list, and we can have all of the members of the team actually meet the patient at the exact same time. So it's a true multidisciplinary clinic. So we call this global aortic stenosis, or GAS for short. We always joke about how we're passing hot air and make various, various jokes. But at the end of the day, I actually think it adds something to the workup process. And as I said, all aortic stenosis patients are triaged at the exact same time. This is a very separate meeting. This is not a working meeting for TAVR clinic or a TAVR board meeting where we're planning upcoming procedures. This is purely for the reason for triaging patients before they show up to the clinic. So this is very upstream of when we typically meet our patients. The goal are to reduce patient travel. In our system, you can see patients come from all over the place. Reduce redundant appointments. Avoid duplication of workup. Consider all treatment options up front rather than after the initial surgical visit. And we do a virtual review, just as I mentioned, with all of the members present. And our nurse practitioner basically presents the case, reviews the STS score, and any potential high-risk features for either therapy, and then we actually consider all therapies on an equal footing. Now, of course, we have to follow the CMS recommendations and the guidelines, so we do make sure that we have 2 surgeons that evaluate the patient when they come to clinic, and we do make sure that they fall into the appropriate STS category, but this rapidly accelerates the process. And we look at the actual primary data and make decisions. When we set up the clinic visit, we basically are ready to go.
And we're done with the consult, huh? Because we're 4.
Oh, we're over. So perfect. So let me just wrap this up. So we've been able to dramatically reduce the time from initial consult to treatment. We've reduced surgical office visits by 60%. So in having more meetings, we've actually reduced the amount of work the surgeons had to do in the office, which they're incredibly happy about. We've improved the collaboration between the services. And now we've started to expand this to other valve disease processes. So if you have mitral regurgitation, we have a similar process. If you have multivessel coronary disease, we have a similar process, and so on and so forth. And the most important thing is it allows you to actually integrate device trials into your daily practice, as opposed to thinking of them as 2 separate entities. So I would argue this system actually allows us to integrate into new technology quicker than anything else. And this is just a slide showing that there are lots of mitral valve therapies, which have already been discussed during this panel, and we're doing the exact same thing. But we include the heart failure physician in the triage process, and the heart failure physician actually uses the lessons that we learned in COAPT and says, this patient needs better optimization. We can do all this virtually before we ever even meet the patient. So by the time we meet them, they're absolutely optimized. So in summary, it is possible to embrace innovative technology in a capitated healthcare system. There are some key elements which are listed right here: physician-driven system, concentration of expertise, and multidisciplinary collaboration. And I would argue that the inherent efficiency of an integrated healthcare model actually allows for rapid dissemination of available technology and adoption of new techniques. Thank you.